Okay, so got it up, got it up and running now. Waiting for you guys to come back. Okay, thank you, Jill, for inviting me, and so glad that you're here today. So I thought what I'm going to do is to talk a brief overview of acromegaly, but anticipate that there will be some interruptions because when Dr. Little is ready, then he will come jump in, and then I will, work around his schedule. Okay. So probably some of the things I'm going to talk about is probably not some things that you probably don't already know, but maybe there are things that new developments and new ways of tackling the disease and how we look and approach and manage these diseases uh, are constantly changing, taking into consideration of new developments and also new drugs as well. So these are my disclosures. So just a brief overview. So what is really acromegaly? It's really a condition where there is excessive growth hormone exposure, which consequently leads to excessive IGF-1. And IGF-1 primarily it comes from the liver, which is generated and driven by the stimulation from growth hormone that comes from the pituitary gland. As you've heard, it's not common. This is these are the numbers of the prevalence, but I'm sure that, and these are obviously diagnosed cases, so obviously that the number is probably going to be larger if you take into consideration that there's probably going to be a good proportion of patients that are underdiagnosed. And as you can see, the diagnosis is often delayed by at least 5 years. I'm glad to say that in the last few years, the number in terms of the duration of diagnosis has actually come down from previously was about this now is about 5 years based on some studies that were done in Europe. The comorbidities can be permanent, some of them transient and come and go, some of them actually permanent, and often they can have a huge impact on quality of life. These are the features which, again, and the reason why you see there's variable, um, the different types of clinical picture and clinical presentation is because growth hormone receptors are found in all over the body. And and you really need growth hormone receptors in all over your body because that's how growth hormone works. And that's why you grow and your organs enlarge as you get, and during the time when you're going through childhood and puberty. So these are some of the symptoms that I've listed below, the ones that are obviously important and prominent and certainly needs to be monitored and kept a close eye on: headaches, fatigue, uh, colonic polyps, which is the reason why colonoscopies are recommended periodically, and in fact earlier compared to the general population. Resistance and the risk of developing hyperglycemia and diabetes, high blood pressure, arthritis, and skin issues as well. And so the thing is with acromegaly is the fact that although it is an endocrine disorder, which an endocrinologist is usually managing this, you can see that pretty much, I'm sure many of you have seen pretty much many other specialties. And indeed, we need them because this is certainly a multi-organ disease, which requires more than just one pair of eyes, and certainly many pairs of eyes are needed to optimally manage and hopefully improve the quality of life of our patients. And that's no surprise because, in fact, sometimes patients who are presenting without the diagnosis of acromegaly, and they often are being see various specialties, and or they end up coming to see an endocrinologist. Okay, so as you can see here, in this slide, the causes of acromegaly can be um, the main cause usually typically is the pituitary tumor, as you can see there and in the figure. And very rarely there are other tumors that arise from other parts of your body that can actually manifest themselves. But the main causes of acromegaly is really a pituitary tumor, of which more than 99% of the time this is the case. And you can see that there are now recently identified genetic syndromes that are associated excess growth hormone production, as you can see here at the bottom there. And these genes are now increasingly identified. And certainly those of us who are seeing patients with acromegaly, we need to obviously make sure we ask patients about the family history, which is obviously going to be very important when you're managing and following these patients up, and also identifying family members as well that may be affected. But thankfully, the genetic syndromes are not common. By far majority of them, it's sporadic causes of acromegaly. And you can see here that it starts off with the excessive growth hormone being produced from these pituitary tumor cells that then affects the liver, increases the production of IGF-1, which leads to overgrowth and metabolic dysfunction. Rarely, like I said earlier to you here, you have the pancreatic tumors and lymphomas, and also the other types of tumors that can also produce excessive growth hormone. But this, like I said, represents a small proportion of patients, less than 1%. How to diagnose acromegaly? Again, certainly, I tell my medical students that they have to always think about it. You'll never diagnose it if you don't think about it. And therefore, if you don't think about it, you're not going to screen for it. And you're not going to screen for it, patients are not going to be diagnosed. The screening measures typically starts off, the diagnosis is actually not that difficult if you compare that with, say, Cushing's syndrome. The only problem is that if you need to think about it. So think about it, and then you're measuring an IGF-1. Again, if it's normal, acromegaly is usually unlikely. If it's elevated, and certainly if it's elevated but not very high in terms of IGF-1, then typically we recommend for oral glucose tolerance test. I'm sure some of you may have had that. It's that glucose drink that you drink fasting, and then blood measurements are taken every 30 minutes for 2 hours. And simultaneously, during those measurements of glucose, we also measure growth hormone, and usually when the growth hormone levels are supposed to be suppressed when glucose levels rise during the tests of the OGTT, and if that's not the case, then the diagnosis is confirmed. However, the OGTT does not need to be performed if you have a very, very high, well, 2 or 3-fold, and that is actually sufficient for the diagnosis to be confirmed. And then once you've found the diagnosis, then the next thing to do is then to find where is it coming from. And that's when you do the MRI of the pituitary. And generally, often the case in acromegaly patients, you'll see that the tumor is often visible and often large because the tumor is often going to be there for a long time. And therefore, it's not that difficult to spot when you're doing the MRI. Again, when you look at the MRI and you see the tumor there, then it's important also for the surgeon who's going to be considering surgery to see whether is this a tumor that represents a good or not good or even a poor surgical candidate. Because if the tumor is seen, but the tumor is difficult to access, then maybe sometimes what we do is to remove most of the tumor followed by medications or radiation. So it really depends on the size and the location and the degree of extensiveness as well. This is a little bit small, but I just wanted to highlight the fact that now more and more studies are now being studied looking at different types of acromegaly samples. And we now know that there are different types, subtypes, we call them. There's the densely granulated tumors that you can see in the microscope, which generally causes quite marked increase in growth hormone and IGF-1. And we know that this is the case with the pathology. The treatment is usually responsive. They are usually quite responsive to somatostatin receptor ligands as well. Then there are the sparsely granulated tumors, which are not that easy to treat medically, and certainly they are generally more aggressive. And these are the types of tumors that typically tends to present in younger patients and generally may not respond as well to somatostatin receptors, and therefore the general treatment is either to consider radiation and pegdizomant as well. And then if you go down the list here, you'll see that there are different types of different tumors now, growth hormone and prolactin, sub-co-secretors. Again, that's also helpful to know because then we can also decide on the types of treatment for the patient and also predict the responsiveness of these tumors to potentially radiation if that is needed. So why is it so important to diagnose early and effectively treat acromegaly? As you can see, there are many patients often present with many symptoms, and the main purpose or the main goal is really to alleviate the symptoms or at least minimize and reduce these symptoms because they are often debilitating and can affect the lifestyle and impair the quality of life. We do know that by improving these symptoms and reversing these comorbidities, it does translate into improving the longevity of the lifespan of patients as well. And certainly, we also want to preserve pituitary function because don't forget, these often are large tumors, which can affect other hormones as well. And therefore, patients can present with other problems as well, which I'm sure you all know. And then finally, at the end of the day, is really to improve the quality of life of patients so that patients can live a life that is meaningful and therefore not be affected by this disease. So the treatment options, again, I'm just quickly going to run through them. Obviously, the moment when the diagnosis is made, typically surgery is often the first line treatment or the preferred option. So I'm going to list down here the various things that we consider when we are considering surgery. So when to consider surgery is typically the first line. And in general terms, the idea is not only is really to reduce the IGF-1 that is high. And so in most cases, with small tumors, the success rates in the hands of an experienced surgeon generally is roughly about 75 to 90%, which is pretty good. Obviously, not surprisingly, if the tumors are larger, then the success rate of IGF-1 normalization is a little bit lower, roughly about 40 to 60%. And then generally also, given that these tumors are large, the aim also is not only to lower the IGF-1, but also to reduce tumor, preferably by completely removing it, or if that's not possible, then to debulk the tumor so that we can then decide on the next step of management, which is either treatment with medications or radiation in that order. The positives of surgery is that symptoms generally improve fairly quickly after surgery, but the negatives is the fact that there may be surgical or hormonal complications, which again, patients need to be monitored for lifelong after having had surgeries. So it's important to find an experienced surgeon because we know that in the hands of an experienced surgeon, the success rate tends to be better, and it's important to be managed in the center of excellence because this is definitely a multidisciplinary disease, which often requires many teams to manage various symptoms that patients do present with. Now, in terms of treatment with medicines, there are different types. I'm just going to list them down here. You can see the somatostatin receptor ligand, or I abbreviate them as SRL. And you can see that there are several options there. You have the two injectables, first generation, somatostatin and sandostatin LAR. They are often administered every 4 weeks, although in some patients, the injections can be adjusted in terms of the intervals, depending on the symptoms and also the control of the IGF-1, so that although typically it's 4 weeks, you can actually adjust it to about 5 weeks or maybe even earlier, about 3 weeks. But generally, it's about 4 weeks. Azirotide is the newer generation of SRLs. Again, there's a short-acting version, which is twice a day, and there's the long-acting version, which is every 4 weeks as well. And then, as you've heard recently, there's also the oral octreotide mycapssa, which is a tablet version of the SRL, which is the only oral medication that is currently approved, certainly in the US, and it's given or it's administered twice a day. Typically, generally, it has to be given away from food because it's required for the absorption, and food can affect the absorption. So it's twice a day, one hour before or 2 hours after meals. And then you have the other options, which is dopamine agonist, cabergoline, which you may or may not have heard about. This is a medication that we often use to treat patients with high prolactin levels. But it can also be effective in patients with acromegaly because of the way it works in reducing growth hormone production through the dopamine receptors in the brain, or at least in the pituitary. And it's given generally, typically once or twice a week. It's long acting, so it's quite easy to use, and generally it's obtainable because it's the cost is actually quite low when you compare this to other medications. And then finally, you have the receptor antagonist, which is pegdizomant, which is the injection that is approved for use every day, although some patients we can use it once or twice a week because it's also fairly long acting as well. So when to consider, it's generally not considered the first line, although in some rare occasions it's considered first line, especially in patients who are not suitable candidates for surgery. But by far majority, most of the time, it's actually second line treatment. In terms of its ability to normalize IGF-1, it's roughly about 30 to 55% with injectable SRLs, and roughly about 60 to 70% with oral octreotides, and in 20% with pasireotide in resistant patients. In terms of the ability to lower or shrink the tumor, it's roughly between 11 to 50%. And the positives is that it also not only reduces the IGF-1 or can reduce the IGF-1, but in some cases, it also improves symptoms, particularly in some patients where headache is a problem. SRLs can sometimes be extremely helpful in reducing the severity of headaches. But the negatives can be, as you can see here, the list can be a little bit long, and you can see it can affect the gut. It can potentially raise blood sugars because of the mechanism of action, that it increases somatostatin effects. Therefore, it can affect the ability of insulin or secretion in your pancreas. And so the pancreatic production of insulin can be decreased, which can sometimes affect the blood sugars, causing the blood sugars to go up. Gallstones and biliary tract problems can sometimes be an issue, injection site reactions, time-sensitive administration, and occasional breakthrough symptoms as well. Like I said earlier, it can be extremely effective in managing patients with resistant headaches. But occasionally, in the US, we do have some insurance, we come across insurance issues. So occasionally, we may not be able to get the desired medication for patients, particularly for pasireotide, because occasionally we may have to put patients on somatoline first before patients are approved for the use of pasireotide in some occasions. The cabergoline or dopamine agonist, again, it's usually reserved for patients with milder cases. And in fact, it has the ability to lower IGF-1, but not that many, in about a third of patients. And sometimes when you combine it with pasireotide in about 20% of patients. We don't know exactly how much long-term studies on in tumor volume reduction, so the effects it has on tumor volume is still unclear. Certainly, the positives is that it's orally administered, it's very accessible, it's relatively inexpensive, and the experience of using this medication, it's a lot in the sense that it's often used as the first choice drug in patients with hyperprolactinemia, high prolactin levels, and patients with prolactin tumors. The side effects can be sometimes problematic, can affect the gut, and can sometimes cause dizziness as well. So it can be effective when it's used in combination with other medications. And usually there are no insurance issues given the fact that it's relatively inexpensive. Lastly, for pegvisomant, it's the second line again in most cases, although recently there has been a change in the algorithm of using it, and one can sometimes consider using it as the first line in patients who do not respond very well to the somatoline or the sandostatin LAR, so that can be used as first line as well, where there's no tumor concerns. If used in high enough doses, it can actually be quite effective, and certainly in the clinical trials, over 90% of patients respond very well to IGF-1 normalization. The reason the number of 60 to 70% is lower than in clinical trials is because we think that the dosing hasn't been pushed high enough in real-world settings to allow the effect of the drug to take full effect. Because of the way it works, it is stable. It doesn't actually reduce or affect the tumors, although in very rare occasions, it can actually increase the size of the tumor, but that's less than 10% in reported cases. But often we have the experience of using this medication, and we've seen that it can actually improve some of the symptoms of these patients. And contrary to the other SRLs, it can improve blood sugars and headaches as well in some patients. It can affect liver function, and certainly it's not it's certainly more costly than, say, cabergoline as well. So again, obviously, insurance authorization is needed for approval for this medication. So higher doses are certainly needed, and like I said, high enough doses if the side effects permitting, this medication actually is effective in normalizing IGF-1. So we have a good number of medications and also radiation that we can consider. So this slide here is really just a summary of the pros and cons of each individual medication and also radiation effects that we can consider using. And you'll probably hear more about the radiation in another lecture by my doctor later on. So in terms of medications, I use it in monotherapy, single use, or we can use it in combination of other medications as well to reduce the side effects and improve the efficacy. So choosing the right medication is certainly very important for a good fit for a patient, and something that individuals when they're considering the various options for treating patients. So in terms of predictive factors for incomplete or inadequate response to acromegaly treatment, for surgery, again, particularly if the tumor is invasive, if the tumor is wide, and certainly if the growth hormone levels are very high to begin with and young age, surgery can sometimes not fully cure the patient for that matter. And these are some of the factors. Whereas for treatment using lanreotide and octreotide, again, we know that the information we get from the pathology, sparsely granulated, patients may not necessarily respond as well as densely granulated, low expression of the receptor, which makes sense because of the fact that it actually requires the receptor to exert its effect. Younger age and some genetic diseases may not respond as effectively for this medication.
Yep.
As well.
Just tell me in the headset and I'll do it.
And then for pegvisomant, younger age, higher pre-op IGF-1s and increased weight and female sexes. So again, these are factors that we have to take into consideration considering different or the treatment modalities. And then finally, radiation. When do you consider? It's generally after surgery and medication. We can sometimes combine medications with radiation because radiation doesn't usually work immediately, and we need medications to hopefully normalize the IGF-1 while waiting for radiation to take place. And then some studies, it can be effective in about 50 to 60%, but like I said, it does take time for it to work. It doesn't work immediately, and it usually is used in combination with medications. It stops tumor from growing in most cases, which is the biggest factor that we consider radiation, particularly in the aggressive tumors. And in that situation, in some cases, medications can occasionally be stopped, but this is extremely rare in my opinion. And I've not really seen many of those, but in theory, that can be, it is possible. And in terms of the negatives, it takes time to work. It can also affect other hormones, and also it may also have cognitive issues as well. So we generally avoid using radiation in patients. But again, you'll hear more about this in the talk by Dr. Kennedy later on. And again, it can also reduce quality of life, particularly if it lowers further growth hormone, causing growth hormone deficiency. So again, this is a study by my colleague Isaac here in New York, different types of patients, and those patients who are on injectable medications seen in healthcare providers. And what they found is that in these patients, even despite being well controlled, these symptoms continue to persist. And that's the reason why I think managing patients with acromegaly is should not only be based on looking at the biochemical and the IGF numbers, but also looking on the symptoms and how we can improve these symptoms, which is why we need multidisciplinary team effort in order to address these symptoms. So what's new on the horizon? You've heard a little bit about Pathophysiology from Kinetics. There's also campus here as well, where you'll hear about the which is the injectable subcutaneous octreotide. There's also binding helix, but this is a little bit further back. They are only in animal studies. And there's also the AZP3813, which again is only starting in phase 1 studies. So front runners really with toxicity and the octreotide subcutaneous depot, which the companies actually here, and you can talk to them more in greater detail to find out about these new medications that are in the. So in summary, acromegaly is associated with impairment in quality of life. Current surgical, medical, and radiation
Sounds good.
patients, but they all have their own pros and cons. IGF-1 is still the required biomarker that we follow patients on, but these levels can fluctuate and they may not correlate with symptoms at all. And although quality of life may improve, in some patients, some symptoms may actually persist despite improvement in control. There's still a huge unmet need. I'm sure you've heard of this, about better ways of comprehensively following patients up, also managing the symptoms better. There's an increasing array of safe medical therapies we now know, and some new ones coming through the pipeline, which hopefully will improve the quality of life of these patients as well. So I'm happy to answer any questions, and while we're waiting for surgery to come through. Thank you. So if you have any questions, just go to the mics. Also, that's also helpful for those virtually joining in. Pull it out. Yeah. And there's yeah.
Hello?
Yeah.
I know that a number of international countries, a bunch of European countries have registries of patients. Is there any action in the US to establish a registry to help track follow-up in response to therapies?
Well, you want to? Sure. Short answer is yes. And in fact, I wish Dr. Lil was here because it's also his baby. He's also collecting data, and we are collaborating with many sites on surgical outcomes, follow-ups of not only acromegaly, but Cushing's and prolactinomas. So we are doing our own registry, which is about 14, 15 sites now, over a few hundred patients. But there's also other registries as well. And I think Jill also can chime in as well.
Chiesi also had the macro registry, and until recently, and I know that I have spoke with Crinetics. Crinetics is talking about starting up a new registry. You know, it's different here in the US because they're all done separately. It's where in Europe and such, they're all connected. And it really doesn't help us being disconnected the way that it is. But, you know, there are new registries that are trying to be formed.
But yeah, and mining these registries just take a lot of time because every time it's a living registry. It's almost like a plant. You got to have to continuously water it and keep it, making sure that it's up to date. And also getting patients to be followed up is a tough one because sometimes patients move and then you lose track of them. But yes, we do have registries and we are very, very invested in spending our time in following our patients up. Particularly here, we Andrew does a great job in his team that we follow these patients in the registry, which hopefully will be published. The data will be published as well.
They're ready to go on.
Okay. Okay.